Good morning, everybody. This talk, you will see that it is very relevant to your clinical practice because in your OPD scenario, you must be seeing these kind of patients very often. So let's say in every OPD, I presume that you will be seeing 2 to 3 patients per day of problems which is simulating to this issue. Now, root tears is a very common problem. It is seen in about 4.3% of all arthroscopic surgeries. The most common is the posterior medial meniscus root tears. You can have a posterior lateral meniscus root tear also, and that is usually seen with the ligament injuries. So you can have a posterior lateral meniscus root tears, very commonly associated with ACL. Probably today we have one patient who is having this problem, and we'll be going to show you the same thing. Posterior medial meniscus root tears are very common with, if you label them, is early osteoarthritis. So if you are sitting on an OPD, seeing the patient, and most of the patients who are coming with a very minimal X-ray finding of osteoarthritis, most of these patients would be suffering from a posterior medial meniscus root tears. The subchondral edema is very classical. So subchondral edema is a very classical finding of a root tear. What is subchondral edema? Basically, function-wise, a meniscus is basically a shock absorber to the knee. So if the meniscus is torn from the root, then the shock absorbing capacity of the meniscus will go and the bone will touch the bone. So this is a natural progression in 12 months. You can see that this is a root tear happening at around this stage, and it progresses quite quickly to a bone-to-bone arthritis, and the patient may need a sort of a joint replacement surgery here. Now, important thing here is you must realize and diagnose the problem at this stage. And for this, it is imperative that you tend to have a feeling or tend to have a high index of diagnosing this problem with an MRI. So, try to do MRI more frequently at typically this stage, and then you will be able to identify more pathology at this stage so that you can address it at this stage, and maybe you may not be able to avoid this natural history, but you can actually delay this natural history. So instead of this 12 months, this may take the course of about 6 to 8 years. So this is what we can do, or what we can achieve with these sort of procedures. So patients who are not treated will progress very fast. Meniscectomies will not work well because meniscectomy will actually not solve the purpose of the shock absorber. So meniscectomy will not make them functional. Subtotal meniscectomies or conservative treatment, they will not work. They will have a very high risk of progression to the knee replacement. Now, you may be seeing a lot of patients in your OPD coming to you with osteoarthritis. So this is basically the pathophysiology, how the osteoarthritis happens, how it progresses, and what we can do to stop that, or you want to delay it. Now, osteoarthritis basically is a very common ailment. Everybody sometimes will have it, but the progression starts with a problem in the menisci per se. So what happens is, whenever there is a injury to the meniscus becomes non-functional, and the weight of the body is taken by bone to bone. And we, at the time of my fellowship, we were seeing a lot of patients in which meniscectomies were performed therapeutically for patients like bucket handle tear or something like that. And these meniscectomies came to us for a replacement. So they also tend to progress very fast. So if you are not treating them at the right time, they tend to progress. And our goal here is to make a non-functional meniscus a functional meniscus. And any injury to the root will lead to meniscus extrusion, which leads to a meniscus which is non-functional and which is useless. So we want to make the meniscus useful. So this meniscus root tear will lead to extrusion. So what happens is, this is your meniscus normally. A normal meniscus is this. So that means that if you draw a line between the tibia and between the tibia and femur, the meniscus should be inside it, and thereby it is serving the purpose of load bearing. Now once there is a root tear, this will shift outwards, and this is extrusion, and thereby this meniscus will not be serving its purpose or working to load bear. Now this leads to loss of shock absorber and hoop stresses, and it leads to tibiofemoral contact pressure increase, leading to arthritis. So this is how it starts. So this thinking, this pathophysiology should be very clear in our mind, that how it starts and what we can do to prevent or reduce it. Now arthroscopy as such is non-popular. There was an article in JAMA that arthroscopic surgery is a sham surgery for knee arthritis. It's a very famous article, and it changed the purpose. So what did the article, what the study did is, study makes two parts: patient of arthritis treated with arthroscopy and treated without arthroscopy. And at about 2 years, 3 years, the result was same. There is no difference. But the thing was that the arthroscopic surgery was done for the debridement of the skin condition and these kind of a meniscus tear. So obviously, if you do a debridement, if you do just cleaning, debridement, and if you just sort of trim away the meniscus, definitely the survivorship is not going to increase. It is going to remain the same. So this was the study, and it shows that arthroscopic surgery is useless for arthroscopy. But now with these kind of surgeries, development of these kind of surgeries, now we can do something which can delay or which can prolong the life of the knee. Now root tear by definition is a tear of the meniscus within a centimeter of the root attachment. So root is the place where the meniscus attaches to the bone, and if there is an injury within a centimeter, it is called as a root tear. And there are 5 types of meniscus root tear. I will come into that. Now this is very important diagram. If you see the medial meniscus, this is the root. If you see lateral meniscus, this is the root. But if you see the lateral meniscus, it is more circular. If you see the medial meniscus, it is more semicircular. And the distance between the anterior and posterior root is too much. So here to here, the distance is too much. And if the tear is here, supposedly, if you have a tear at this position, the meniscus will extrude like this. Okay. Now actually it is seen that it is not like this, but it is like this. So the extrusion of the meniscus is anteromedial. Why? Because this is intact and this is torn. So when the patient bears the weight, this is the hinge point, and the meniscus will shift like this. And when the meniscus will shift like this is the region where the load bearing will start. So anybody of you has done any workshop on unicompartmental knee replacement? UK, unicondylar knee. So for UK, this is the classical finding. So if you have an anteromedial arthritis, this is a classical indication without any other issues. So if you have a normal ligament, normal lateral compartment, almost normal patella, with an anteromedial arthritis, this is a classical indication for a unicompartmental knee replacement. So they say that if you have a kissing lesion on tibia and femur, and if you have a wear on this region, anteromedial aspect of tibia, that is a classical indication for you to do a unicondylar knee replacement. Okay, so anteromedial arthritis is commonly starting point of the arthritis, and this starting point is usually as a sequelae of a root tear which is posterior. So the root tear is posterior, but the wear which is coming is on the anteromedial tibia. So when is the wear posteromedial? ACL injuries. So if you have an ACL deficient knee, the wear will be in this region. So if you are doing total knee replacements too often, just see the cut that you make on the tibia, and most of the early arthritis you will see here, and most of the late cases when the ACL deficiency is also there, you will see a posteromedial defect in this region. This is very common. If you are doing total knee replacements, you will be seeing this phenomenon. Posteromedial wear will be there if the patient has the ACL injury. If the ACL is intact, the posteromedial wear will not be there. With the intact ACL, you will have anteromedial wear most commonly. So this, whenever you take a cut next time, just see. And whenever you do your TKR next time, you see that most of the time you are able to excise a full intact medial meniscus, full meniscus. Why? If the meniscus is intact, ideally the arthritis should not have set in. But structurally, in these cases, the meniscus is intact. But functionally, it's not. Because it is torn from the root and the meniscus is extruding medial. So extrusion of meniscus leads to a meniscus tear which is non-functional. Okay? Now Laprade has given this classification of type 1 to 5. Type 1 is an incomplete tear, type 2 is a complete tear, but as I told you that this is a radial tear, and if it is between 0 to 3 millimeters of the insertion, it is type 2A. If it is between 3 to 6 millimeters, it is type 2B, and if it is between 6 to 9 millimeters, it is type 2C. Okay. Type 3 is basically a bucket handle with a root detachment. Type 4 is a complex oblique or a longitudinal tear, and type 5 is a root avulsion fracture. This diagram which summarizes, this is a partial root tear. So this is the case which we saw that day. In this we just pass one suture here and 3 sutures here. So, and this is a complete radial tear. So if it is in this region, it is 2A, this region it is 2B, and this region it is 2C. And this is a bucket handle from the root. This is an oblique tear into the root attachment. This is type 4. And if it is with a bone chunk, then it is a type 5. So everything will fall into the preview of a meniscus root tear, but different patterns. Now we will be coming to the repair of different patterns as well. But first we will see the MRI findings of these injuries. Now this is a very classical sign. This is called as a ghost sign. And ghost sign means you should see the meniscus, but it is not seen. So this is like a ghost. So this is a ghost sign, and this is a very classical finding of a medial meniscus root tear. And this was I was talking to you. This was a extrusion. So this meniscus has started going out. Mind you, this MRI image is a supine image. MRI is done in supine position. So whenever the patient will bear the weight, this extrusion is bound to increase. Okay. Now here you can see that there is a subchondral edema here. Now previously this finding was called as a SONC lesion, spontaneous osteonecrosis of the knee, and now it has been proven beyond doubt that this lesion is nothing but this is a sequelae of a root tear. You can see subchondral edema here also. So this lesion is nothing but this is a root tear. Because of the root tear, the loading is directly here, and this leads to a hyperintensity signals on the MRI. Now again, this is a very important sign. This is called as a truncation sign. Truncation sign is basically this black line should extend from here to here, and if you see a white line here, this suggests that there is a cutoff at the level of the root, and this is suggestive of a root tear. This is again a ghost sign. Now this subchondral edema can sometimes be on femur, sometimes it may be on the tibia. So here the subchondral edema is on the tibia, and you can see that here the mark you will have a lot of whitish edema. So this is again a sign of medial overloading on the tibia. This again is a sign of medial overloading on the tibia. Now you will have two scenarios in your practice. One will be a traumatic injury to the meniscus root, and second will be a degenerative meniscus root tear. Okay. This is more common in obese, middle-aged with a varus alignment. Varus alignment is a high risk factor for a root injury. Now, SONC lesion, as I told you, is actually a root tear. Now, the salient features are varus alignment with a BMI more than 30, posterior knee pain which is sudden onset, popping sensation, the extrusion text will be positive, joint line tenderness will be there. You will be seeing ghost sign. More than 3 millimeter of extrusion is classical for a root tear. You should have a high signal intensity in axial, and sagittally you will have a ghost sign. Okay, so as I told you, this is the medial meniscus. The important thing here that you should realize is the medial meniscus is thickened on the posterior part and it is thinner on the anterior part. So the root is here. This is the attachment of the root, and when the root is torn, the meniscus will shift this way and the loading will shift this way. And this is the area where you will be developing a osteoarthritis. Okay, so this is basically the biopathology of the starting or initiation of osteoarthritis in most of the cases. Now, as far as the lateral meniscus is concerned, you will have a radial tear in this region most of the time, and this is more commonly seen along with the ACL ligament injury. So, along with the ACL, you may have this injury. This is very common. Rarely you will have a solitary or isolated kind of a lateral meniscus root tear. Very rarely. Now, these are specific fibers. These whitish fibers will connect the bone to the meniscus, and this is the area where the root is, and in this specimen the root has been elevated from its attachment. Now the ideal indications are patients should be younger than 65 years, they have a symmetrical alignment of the knee, varus should be less than 3 degrees, you should have mild progression of arthritis and mild subluxation of meniscus. This is the classical indications. Now classically speaking, historically speaking, meniscus root tears were repaired by these two predominant techniques. The first technique was a transtibial pull-out technique, in which they make a tunnel into the root, pass sutures into the root of the meniscus, pull the sutures and tie it over a tibia with a suture disc or buttons or whatever. And the second technique was a suture anchor repair technique, in which from the posterior medial portal an anchor was inserted into the root. Now I have tried this technique, but this is technically very difficult technique, because from the posterior medial portal to have a good trajectory to put an anchor into the root is not that easy. It is a difficult job even for an experienced surgeon. Now transtibial pull-out technique is the most popular technique throughout the world for treating this kind of root tears. But this technique has some problems. The attachment of the root is too far from the fixation point. So there is a long bungee cord effect, and this can move. So the fixation point is too far away from the actual attachment of the root, number one. And number two, there is very less chances of modularity. If you want to repair it in a different fashion, you will not be able to do so. Now this is just a case. So 40-year-old female patient present to me with a pain in the knee since 2 years, which is increasing on squatting and stair climbing. The intensity of the pain increased from the last 2 months, and that is affecting her daily activities. And on examination, there is a posterior middle joint line tenderness, there is no FFD, no coronal plane deformity, and the deep flexion is painful. Now, if you retrospectively analyze your OPDs, this is a very common scenario in your OPD. Daily, you must be seeing 1 or 2 patients of this age group presenting with these symptoms. This is actually a very common scenario in our practice, and most of us will actually ignore them or neglect them, or we will prescribe them modalities which are not proven, like Simlisc injections, like PRP therapy, or maybe we just prescribe them physiotherapy exercises. Now, most of these patients would have a virus, so we should rule out that. But most of these patients, so what is the option that you will do in these cases? So the options are, you can keep her conservative, you can give injections, you can do an arthroscopic debridement, you can do an arthroscopic transtibial root repair, HTO and UK. Now UK is a little bit more aggressive for this kind of a early lesion. HTO is one good option, but HTO usually there are 2 things. It is good for a very significant varus deformity, but most of the patient of this age will not theoretically agree to it. And if we want to do later on this, then this is a deterrent. You will not be able to do it properly if you are doing a lot of HTOs. Now these are the X-ray of this patient. So again, this X-ray is very common X-ray that you are seeing. Okay? You will have a minimal reduction of the medial joint line here also. Okay? She is 40. She is young. So definitely she is not at that stage that you consider her for a joint replacement surgery. Now these are her MRI. Now MRI pictures are really bad. So from my perspective also, the disease is advanced. So almost whole of the meniscus is extruded. You can see here. There is a ghost sign here. Whole of the meniscus is extruded here. Okay. Now we did a procedure in her case, which is called as a Rootfix Anchor fixation, and we have called this procedure a meniscus centralization procedure or a meniscus realignment procedure. And this procedure had an advantage that it is a low profile fixation without metallic implants. So this is a very good procedure if you want to plan any procedure for her in the future. Any of the fixation device that we use will not hamper the way of any future surgery. We address the pathology, and the concept is to make the meniscus functional from a non-functional extruded position. This is an all suture device. The fixation of the implants is at the root attachment or at the pathology itself, and there is a very less working length and a very less fungi effect. Now this is the intra-articular video. You can see, as I told you, this is the anteromedial wear, which is very classical in these patients. There is some degeneration on the femur, so this wear is very classical. This is the anteromedial wear, and as I told you, when patients are doing total unicondyle knee replacement, this is actually classical criteria. This is anteromedial wear. So here we are making a high anteromedial portal, and this high anteromedial portal will be used to put anchors which will be able to address this extrusion. And this what we want is we want to deload this area, because actually what is happening here is whole of the body is actually loading on this particular area, thereby leading to a degeneration here. So what we are doing is we are putting an anchor. This anchor is called as an X-fix anchor. This is called as an extrusion repair anchor, and this anchor will actually do a thing that it will reduce the meniscus in between this lesion and the femur. Meniscus is pulled in so that it prevents the chances of a progression of this lesion. So here we are using passers. These are ideal suture shuttles. These are passers which we use for Bankart surgery, and these sutures are passed one by one into this area, which will be railroaded with these threads, and these threads will be taken out one by one. So this is the first. Now this is technically a relatively advanced disease case. This is not an early case. So we need to be very careful, and therefore we are trying to put in more anchor. So here we are putting 2 anchors for reduction of this anteromedial extrusion. If the disease progression is not that severe, you can just go with putting a single anchor. Here we are putting 1 or 2 anchors, and these anchors are sequentially passed into this area. So one by one we are passing the sutures through this defect. So one by one we are passing the sutures in this area. So these sutures, this is the first suture, this is the second suture, and then third and fourth. All the 4 sutures are now tied. Now this will take care of the anteromedial extrusion part, and you will realize that once we have closed all these sutures, this area is partially covered. This area which was exposed initially is now partially covered with meniscus, and some of the load bearing will be taken by the. Now here this is the root. The root is avulsed badly, and now we are using an anchor which is called as a Rootfix anchor on the back of the root. So this first anchor, this will go into this area. So this, you can see that this is it is coming out there. You can see this is the bead pin which is coming out there. We pass a needle into this particular area. And then we'll take out the nitinol wire from there, and we will retrogradely load the anchor from this wire. Now this is easy insertion of the anchor as compared to the posterior medial insertion, as that I told you before, because this is a very simple technique you can do. You don't need very much extra skills to place this anchor. So this is the anchor which is coming in. This is the Rootfix anchor, and this Rootfix anchor comes into its place right there. So when you pull the anchor, the Rootfix anchor is deployed at its own position. So this anchor is deployed at its own position. So once this anchor is deployed there, you just need to pass these sutures through the meniscus to actually repair it. Now this you can do by any pattern. Here we are using a technique which is called as a Mason-Allen technique. So we will be passing 3 sutures one by one, we are passing 1, 2 and 3 sutures, and then we will close it. So when we will suture it back. So once we suture it back, the meniscus will fall into its place. The meniscus will reduce into its place at the root. Okay. So this is the simple stitch, and then we will be using these two wide sutures closing. So this is like a cross closure. This is called as a Mason Allen stitch. This stitch we also use in a lot of time in the rotator cuff repairs. So this is a Mason Allen repair which is completed. This is a simple stitch, and this is a mattress stitch. Okay. So these two stitches are closed on its own place. Okay. Now everything is closed on well, but as I told you, this is an extended indication case. So there is some extrusion is here. So we put another anchor, a Rootfix anchor on the posterior middle aspect. So basically what we are trying to circumferentially put anchors to bring the meniscus back into a functional position. So this is again a fourth anchor. This is again a Rootfix anchor. So we put two anterior Rootfix anchors and two posterior Rootfix anchor, which are used to pull the meniscus into its place. So this is the fourth anchor, again a Rootfix anchor, pushed into its position, locked there, and we'll pass sequential sutures there to actually reduce it back into its position. So this makes a good sense of reducing the meniscus back into its place. Now this, because it is a central anchor, you have to do a mattress suture. So all the four sutures are passed in a mattress fashion, and all the four sutures are passed, and then you will repair it. So basically, by doing this, we are hoping that we have reduced the meniscus which was extruded into the joint, and probably the meniscus will function more, and thereby we can offer a little bit more life to the knee as compared to before. So the progression of osteoarthritis will be delayed, and we may delay the age of the knee replacement per se. And if there is a defect on the femur also, so this defect was covered with a microfracture surgery. So we'll just put small holes into that, and now it has a better chance to heal because there is a meniscus in between also. So probably this will have a better chance to heal. Now the other advantage is even the bad patterns can be addressed. So if this is a pattern, then you can stitch one suture here and one suture here, and then you can repair it. So if you have a radial tears, you can repair them in a side-to-side fashion. So thereby this device, the Rootfix Anchor, is an advantageous fixation over the traditional transtibial technique, because there you have no modularity. You just have to pass sutures, tie it back on the tibia. Here you have modularity options. So you have one anchor with 4 threads which is there, and these 4 threads can be used in different directions, in all sort of permutation combination to reduce it into its place. So technically you can do a better sort of a fixation and more modular fixation when using this technique. Thank you.
Thank you, sir.
You can have your breakfast and we can continue.